Good afternoon, everyone. Thank you for joining us today. We're going to give it just a minute to let everyone join before we get started. All right, good afternoon, everyone. Thank you for joining us today for our webinar on evolving the Outpace CVD program, Target Type 2 Diabetes. Before we begin, I'd like to share that this meeting is being recorded and slides will be available to all registrants after our call today, as well as in the handout section of GoToWebinar. Please be sure to type any questions that you might have into the questions feature, as all attendees will be in listen-only mode today. Closed captioning is also available. We've also included a quick disclaimer. This presentation today is for educational and informational purposes only. I'm going to kick us off with introducing today's speakers and quickly running through our agenda. My name is Liz Montgomery. I am a program consultant on the Outpatient Quality Team at the American Heart Association, where I manage the operations of Target Type 2 Diabetes, as well as our other core programs and initiatives in Outpace CVD. I'm joined today by my colleague, Megan Polner, who is also a program consultant. In addition to that, Megan has numerous qualifications in healthcare, including being a registered dietitian and certified diabetes care and education specialist. We are also grateful to be joined by Dr. Michelle Chu. Michelle Chu is an assistant professor of clinical pharmacy at USC Alfred E. Mann School of Pharmacy and Pharmaceutical Sciences. As a lead clinical pharmacist, she has established various pharmacy services and managed high-risk patients with multiple uncontrolled chronic disease states at various safety net clinics affiliated with USC Mann. Her work continued as she became a program director for PGY1 pharmacy residency at Los Angeles General Medical Center. Her area of interest is chronic disease management by integrating pharmacy practice into outpatient clinics. She also serves on the American Heart Association's Outpatient Quality Advisory Group, where she has played an instrumental role in developing various diabetes resources for our Outpace CVD suite. We're going to begin today by giving a brief overview of the history of Target Type 2 Diabetes and the path to evolving the program. We'll discuss our commitments and guiding principles, and then we'll introduce new evidence-based activities that will be asked as part of the annual data submission process. We'll have a brief time, maybe 5 to 10 minutes, for a Q&A at the end of the call. As we get started, we'd like to know a little bit about your organization's prior engagement in Target Type 2 Diabetes. If you've submitted data in the past, has it been for 1 year, 2 to 3 years, or maybe it's been for over 4 years? Or have you possibly utilized resources from the program or from Know Diabetes by Heart? Or maybe you're brand new and this is your first introduction to the program. We'll give it just a few seconds to see the results. All right, I'm seeing we have right now about an even split between organizations who've participated for 2 to 3 years, 4+ years, or who are brand new to the program, with a few falling in the other categories, and that's pretty steady across the board. So welcome, and it's wonderful to have such a mix of organizations with us today. Target Type 2 Diabetes is one program under the umbrella of Outpace CVD. The American Heart Association's Outpace CVD suite offers technology solutions and QI support for organizations participating in our programs and partnered initiatives as they target cardiovascular disease. Our goal is to connect guideline adoption, evidence-based programming, and systemic systematic approaches to addressing and reducing chronic cardiovascular diseases treated in the outpatient space. Our program, Target Type 2 Diabetes, was first introduced with support from No Diabetes by Heart, or KDBH, which was a joint initiative with the American Diabetes Association. Our focus in this program continues to be addressing cardiovascular disease risk in patients with type 2 diabetes. Our first award year was in 2020, and we've seen steady growth in participation with a tremendous increase in 2025. But our award criteria over this time has not changed. We have a Participant Achievement Award that recognizes practices that have completed data submission, including clinical measure entry, and who are committed to improvement of CVD in their patients with diabetes. We also have a Gold Achievement Award, which includes the same requirements, plus they need to meet the specified thresholds for 2 clinical measures. What has changed over the years is that we folded in additional attestation questions to help organizations focus their QI priorities. These questions have also provided the AHA with insight into resources that our participants might need. In turn, we've been able to create new Outpace CVD and Target Type 2 Diabetes resources that are focused on these self-identified barriers. That said, we've also received some feedback that some of the included questions have been more or less helpful than others, and that our audience is interested in more quality improvement opportunities as part of participating. No Diabetes by Heart also sunset earlier this year, which has given us the opportunity to update and refine resources that better align with our program. One resource that we've recently introduced is our Ready, Set, Go implementation guide. This one is on standardizing diabetes management for the reduction of CVD. This resource will continue to align with the updates we are introducing today, and I'll flag that the Ready, Set, Go guides are something you can expect to see more of in the future for our other Outpace CVD priorities. In this document, we outline a structure that helps organizations evaluate their current practices, develop an effective diabetes management plan, and integrate policy into their current care practices. So Ready focuses on self-evaluation with an embedded checklist, a model share for peer review, and addresses equitable health. Set collates all of the tools that are needed for integration. So in this section, think of professional education, treatment algorithms, addressing comorbidities, and team-based care. And then lastly, the Go section, which is putting those policies into practice. So think of how to leverage technology for implementation, dashboard, shared decision-making, and a really great prior authorization model share. The decision on why and how to evolve the program also came through direct feedback to our team. This is through multiple ways. So through the joint American Heart Association and American Medical Association's Target BP survey that we held in 2023, through an AHA 2024 recognition consulting evaluation that was organized by a third party, and through direct feedback in our Outpace CVD accelerator programs, as well as just across the board feedback. Some highlights are that organizations continue to give improving patient outcomes as the #1 reason to participate. Many of you are likely familiar with the Target BP Pillar Framework, which was introduced 2 years ago. Organizations have strongly agreed that this pillar structure and framework helps them to focus QI priorities, to outline concrete steps for quality improvement, and to translate the evidence into practice. And of course, that's really what we're trying to do across the board. The pillar structure has also been appreciated as providing a checklist for sites. And we've heard that our award structure is clear as it represents rungs on a quality ladder. All of this was really carefully considered and brought us to our main program evaluation goals. First, we want to provide a clearer roadmap for organizations in their risk reduction of CVD for patients with diabetes. By utilizing a similar pillar structure to Target BP, We aim to be better able to support you in identifying your QI priorities and making actionable, sustainable, and trackable changes. Secondly, we want to provide an award growth opportunity for those at both the participant and gold level. We aim to be able to offer award categories that recognize implementation of these activities in addition to just measure performance. We want to provide those rungs on the ladder to encourage continued improvement. So what does this look like from a logistical perspective? How quickly are awards going to be impacted? Today, we'll be announcing what the new evidence-based activities that will replace the current attestation questions will be. The rest of this calendar year, we're going to encourage organizations to begin using the structure for self-assessment of current practices. Our local AHA staff will be there to assist in providing resources during this process. Next year, when data submission opens in January, we'll be including these questions in a dry run year, looking at activities that were completed during the calendar year for 2025. This data is going to provide us with a baseline of understanding where all of our various target type 2 diabetes participants are currently at, so we can make realistic benchmarks for the new award categories. We'll announce those new award categories next year, which will be after the data submission closes. And then in 2027, we will roll out the new award categories. This means that you'll have about a little less than a year and a half to make any QI changes that might be affected in those awards. So moving along, I'd like to hand things over to Dr. Michelle Chu for her to share a little bit about our commitments and principles before Megan walks us through the activities themselves.
All right, thank you, Liz. Hi, everyone. I am very honored to be part of the Target Type 2 Diabetes Evolution through the work group and the Outpatient Quality Improvement Advisory Committee. So I'll present briefly on our process and guiding principles that helped us develop this program. Next slide, please. So why did we even want to evolve this Type 2 Diabetes Quality Program? So as you know, about 11.6% of the US population, that is more than 38 million Americans, are living with diabetes. And another 97 million Americans have pre-diabetes. Diabetes is a debilitating chronic disease where, if not well controlled or managed, people will experience serious complications such as kidney disease and cardiovascular disease. Patients with type 2 diabetes and kidney disease are 3 times more likely to die from the cardiovascular event. And cardiovascular disease is the leading cause of death for people with type 2 diabetes. But unfortunately, only about 1/3 of people with diabetes have discussed their cardiovascular disease risk with their clinicians. And these are scary facts, and it actually led the American Heart Association to prioritize managing both diabetes and other risk factors to reduce cardiovascular disease events in patients with type 2 diabetes. Next slide, please. So as we were making decisions for the content of the program, we were led by these 6 guiding principles. The first is to leave no one behind. So we wanted to ensure that participants like yourselves could keep up with the changes being presented given an appropriate amount of time. Secondly, the evidence-based practices were very important to us, and we ensured that all the proposed changes were based on published best practices. Then we also took into consideration that activities are actionable and measurable. So it can also help your organization to track changes year over year and how these are affecting, for example, A1C control rates. We were mindful that each participating organization has general capacities to provide and produce multiple outputs, including data processing capacity and QI support. And one of the areas we can find a bit challenging was that we also knew we couldn't include everything that mattered in quality improvement and every detail of explanation. So, with this on our mind, we intentionally crafted questions to be well rounded. And finally, it was very important that our focus was aligned with American Heart Association priorities, which were focusing on the reducing risk for cardiovascular disease in patients with diabetes. So we did not get into the details on the diabetes standards of care. Next slide. The evolution of the target type 2 diabetes took a lot of different stakeholders reviewing, discussing, questioning, and revising over and over the last several months. National Outpatient Advisory Group, which is composed of the majority of the clinicians and health administrators, provided their clinical and operation expertise, identified evidence-based priorities, and finalized the content. Our multiple focus groups were involved, including participant focus groups from participating organizations and the American Heart Association Community Impact Focus Group from the team working with local healthcare organizations on a day-to-day basis. These focus groups provided great and in-depth feedback through active discussions. American Heart Association internal leadership and AHA Diabetes Cross-Functional Work Group also played important roles, providing their guidance and expertise as leaders of the Diabetes and AHA Society. Lastly, I have to and I want to acknowledge and sincerely thank the dedicated staff of the AHA Outpatient Quality Team. Their tremendous efforts in organizing and coordinating diverse stakeholders, developing a comprehensive framework, sharing languages, guiding the process through multiple revisions and stakeholders' presentations were instrumental. This was truly a collaborative effort, and the AHA staff's deep expertise in working with health organizations and outpatient quality initiatives was key to moving the work forward seamlessly. So I really thank them. Now I'll turn it over to Megan, who will go into details on the pillars of target type 2 diabetes.
Thank you so much. I am very excited to announce and unveil our new pillars for target type 2 diabetes. Today, I'll be walking you through each one of the pillars individually. We will be reviewing all of the language of the new questions that we will be asking, and I will also provide resources for each of the pillars to help your organization support the adoption of the evidence-based activities. On the next slide, we wanted to start with one of our new clinical practice questions related to prediabetes. All of our work groups thought it was really important to include a question about prediabetes because we understand and recognize that a focus on diabetes prevention is a really important part of the care process. We also know that many individuals who are diagnosed with prediabetes will progress to a diagnosis of type 2 diabetes in the long run. And so we wanted to ask this clinical practice question first to really highlight and emphasize prevention efforts that healthcare organizations may be engaging in. So this first question reads, which of the following guideline-directed treatment and prevention efforts does your organization deploy for patients with prediabetes? The options read, monitoring hemoglobin A1C and or fasting blood sugar for the development of diabetes at least annually or more often if clinically indicated. Prescription of metformin, education of lifestyle modifications, including healthy eating and physical activity, referral to diabetes prevention programs, promotion of weight loss through lifestyle modification or pharmacotherapy when indicated for those with obesity or overweight, and lastly, I don't know / I'm not sure. And again, this question really will help organizations to focus on their prevention efforts. Now we will get into our new pillar structure for target type 2 diabetes. Many on the call likely submit data for target BP. And as Liz mentioned, we really want to keep continuity across our programs and also respond to the feedback that we've received from healthcare organizations that they like our questions and our evidence-based activities to be organized in this way to serve as a QI checklist. So you can see on your screen here that we will now have 4 pillars in target type 2 diabetes. The first pillar will focus on assessment. The second pillar focuses on treatment. The third pillar focuses on patient partnership and lifestyle modifications. And then lastly, we have our equitable health outcomes pillar, which is in alignment with the equitable health outcomes pillar that you have seen in target BP. So on the following slides, as I mentioned, we will get into the details of each pillar. So starting with assessment here, we'll first review the breakdown of the structure of each one of these pillars. So we start here with our assessment pillar with the policy element, and that is related to having a diabetes standard of care that is documented and available across the continuum of care. Next, we have a practice assessment, which relates to monitoring to assess the use of that standard of care. And then we have 4 elements that look at the content of the policy and practice. For the assessment pillar, we have the assessment of glycemic control, the assessment of kidney health through eGFR and UACR, the assessment and evaluation of multiple comorbidities, and looking at a team-based care model. The next slide will read through the questions in their entirety. And I will point out, you'll see at the bottom of your screen, we do have footnotes. If these are difficult for you to read, we do have these slides available for you in your handout, and I will read over them here for clarity as well. The assessment pillar question reads, I attest that my organization uses a medical standard of care focused on diabetes management and CVD risk that includes, at a minimum, standard of care here is defined as any policy, protocol, or formally adopted process that is routinely and systematically used across the entire organization as part of standard practice. Question 1 reads, an established diabetes standards of care policy that is documented and available across the continuum of care. Question 2, monitoring to assess the use of the standard of care in practice, with monitoring being defined as through an analysis of EMR population health data, at least annually, to assess if the policy or protocol is being followed. This requirement does not specify a level of adherence to the policy or protocol. Question 3, assessment of glycemic control as measured by hemoglobin A1C at least 2 times a year or every 3 months for patients not at goal. Question 4 has 3 components broken down into A, B, and C parts. So first we have assessment of eGFR annually. Next, we have assessment of UACR annually. And lastly, we have use of the KDIGO heat map for kidney health classification based on the results of both eGFR and UACR measurements. Question 5, assessment and evaluation of comorbidities into the standards of care. If this question is selected yes, then you'll be prompted to select which of the following are included in your standard of care for evaluation. And the options include chronic kidney disease, hypertension, ASCVD, dyslipidemia, and obesity. And the last question for the assessment pillar, question 6, collaboration through a team-based care model that provides comprehensive continuity of care for patients with diabetes. Team-based care model is inclusive but not limited to internal or external collaboration for the purposes of promoting continuity of care, such as partnership with community pharmacies, diabetes educators, specialist referrals, community health workers, and others. Next, we will give a brief overview of the resources for the assessment pillar. Liz already highlighted the Ready, Set, Go implementation guide, and we'll highlight it several more times throughout this presentation, just to highlight some of the key areas that relate to the pillar that we are reviewing, so that you know where to find the information in the guide. So for our assessment pillar, we recommend reading through the Set section to help you with setting the standard of care. Additional resources include a webinar on team-based care strategies to improve patient outcomes, a short resource guide that overviews kidney health and type 2 diabetes. We have a reference here for the 2022 KDIGO clinical practice guideline for diabetes management and chronic kidney disease. Additionally, this table 4.1 provides a checklist for the components of comprehensive medical evaluation at initial, follow-up, and annual visits that can be used in your development of your standard of care to ensure that your organization is adhering to guideline-directed assessment practices. And then lastly, we have provided a copy of the KDIGO heat map for your reference, so that you can use that in the classification of kidney health for patients with diabetes. In our next pillar, we will again provide an overview seen here for treatment. And again, we follow the same structure as our assessment pillar. So we start with our policy element, which includes a treatment algorithm or protocol. And then we have our practice assessment, again, monitoring here to assess the use of the treatment algorithm or protocol. And then again, we see the 4 elements contained within the policy and practice. First being the treatment goal of an hemoglobin A1C less than 7 when clinically indicated, prioritizing SGLT2 inhibitors and GLP-1 receptor agonist when clinically indicated, a treatment goal for LDL cholesterol, and a treatment goal for blood pressure. So we'll look at these in depth on the next slide. So the treatment pillar question reads, I attest that my organization uses a guideline-directed standard of care to treat patients with diabetes that includes, and I'll note here that standard of care has the same definition that we used in the assessment pillar. Question 1 reads, standardized use of a treatment algorithm or protocol with standard use being defined as any protocol that is documented or organizationally accepted and is systematically available. Question 2, monitoring to assess the use of the treatment algorithm or protocol. And here monitoring follows the same guidelines as the assessment pillar. Question 3, setting a treatment goal of hemoglobin A1C less than 7% when clinically indicated. You'll see we have a footnote here just to describe that less stringent glycemic goals may be appropriate for individuals with limited life expectancy or where the harms of treatment are greater than the benefits. Question 4, prioritizing SGLT2 inhibitors and GLP-1 receptor agonists in the treatment algorithm or protocol when clinically indicated. And I'll clarify here, because we have received lots of data in previous years related to the barriers for prescribing these medications. We know that those barriers are numerous and can include things such as limited formulary access, cost concerns, and patient reluctance. I just wanted to clarify here that the prioritization of these medication classes should be in the treatment algorithm itself that is being used systematically across the organization by clinicians. However, we understand that often there may be barriers when it comes to the prescription of these medications. Question 5, setting a cholesterol treatment goal of LDL-C less than 70 milligrams per deciliter for patients with ASCVD risk factors. And question 6, setting a blood pressure treatment goal of less than 130/80 millimeters of mercury for patients with hypertension. Again, we have a footnote here just clarifying that patients with confirmed hypertension and CVD or 10-year CVD risk of 10% or greater when clinically indicated. I'll also note for Question 6, that our blood pressure treatment goal is aligned with the blood pressure treatment goal used in Target BP, thus furthering the continuity between our programs and utilization of same guideline recommendations. Next, we'll look at the resources for the treatment pillar. Again, you can see on your screen, we've highlighted the Ready, Set, Go guide and recommend that you read through the SET section for examples of useful algorithms. Additionally, we've provided a link here for the American Diabetes Association Standards of Care in Diabetes for 2025. This resource provides many treatment algorithms that you can utilize to standardize care. One of them being Figure 9.3, which reviews the use of glucose-lowering medications for patients with diabetes. Additionally, we have a webinar that provides CME that covers acting rapidly for hypertension control. And then coming soon, we're very excited to share that we will have a new resource launching shortly. This will be a job aid resource that covers managing and reducing risk of complications in people with type 2 diabetes, and it will cover some of the comorbidities of type 2 diabetes and pharmacological ways that we can reduce risk. Next, we will move into our third pillar, which is patient partnership and lifestyle modifications. Again, this pillar follows the same structure as our previous two. We start with a policy element, again with a standard of care to assess risk factors and non-pharmacological interventions. Then we have monitoring, yet again, to assess the use of the standard of care in practice. And then we have our 4 elements for the content of the policy and practice. We start with DSMES or equivalent services. Then we have obesity counseling and weight management. Next, we have ASCVD risk estimation calculators. And finally, we have interventions with patient engagement. On the following slide, we'll review the full content of the questions for patient partnership and lifestyle modification. So this question reads, I attest that my organization provides risk factor assessment and non-pharmacological interventions for patients with diabetes to support positive lifestyle changes that include, number 1, a standard of care for the assessment of risk factors and use of non-pharmacological interventions. Again, standard of care here aligns with the definition on our previous slides. Additionally, question 2, monitoring to assess the use of the standard of care in practice aligns as well. Question 3, provides access to diabetes self-management education and support, also known as DSMES, or equivalent services. You'll see we have a footnote here to define the minimum requirements for DSMES or equivalent services, which includes pathophysiology of diabetes and treatment options, healthy coping, healthy eating, being active, taking medications, monitoring of blood sugars, reducing risk by treating acute and chronic complications, and lastly, problem solving and behavior change strategies. And question 4 provides access to obesity and weight management. Question 5, a discussion of ASCVD risk estimation results derived from CVD risk assessment models, including but not limited to the pooled cohort equation or predicting risk of cardiovascular disease events, also known as PREVENT. And lastly, question 6, engaging patients in interventions to address tobacco and vaping cessation, alcohol moderation and cessation, and depression as indicated by validated screening tools. On the next slide, we also have resources to support you in achievement of the patient partnership and lifestyle modification pillar. Again, up on the screen, you'll see the Ready, Set, Go guide. You can read through the SET section for details on DSMES and the Go section for tips on leveraging technology, shared decision-making. And again, as Liz noted, we have many helpful model shares contained within the guide. We have a model share related to peer review to assist you in your monitoring of your adherence to your protocol. And so we would recommend checking out this resource after the presentation today. Additionally, we have provided a link for you to the development and validation of the American Heart Association's PREVENT equations, as well as the license agreement if you wish to utilize this this calculator in your clinical practice. We've also provided the scientific statement from the American Heart Association on the implementation of obesity science into clinical practice to assist your organization in implementing programs related to obesity and weight management. We understand that there are many, many screening tools that can be utilized for the conditions that we've recommended, but we have linked a few here for your reference, including the PHQ-9 depression screening tool, the audit alcohol use disorder screening tool, and then also linked to AHA's quit smoking, vaping, and tobacco use resource. Additionally, I would like to highlight some new resources that can be found on our website. So first, we have the initiating DSMES referrals at 4 critical times resource that walks you through a checklist of considerations through the 4 critical times for DSMES referrals. Additionally, we have a DSMES referral form that can be used to refer your patients to DSMES services outside of your organization. And then lastly, coming soon, we have key patient resources for healthcare professionals. So keep your eye out for those after the presentation, as we will have them uploaded to our website soon. Our last pillar is equitable health outcomes. And again, I want to highlight here that much of this information aligns with the equitable health outcomes pillar in Target BP. So if you're familiar with that pillar, this one should look very similar to you. We start with the policy element that looks at adoption of, again, a standard process to gather race and ethnicity data, as well as assess social drivers of health. Again, in this pillar, we see our practice element, which relates to monitoring of the standard processes. And then we have our 4 content elements. First, we have training the care team on techniques to gather data per the standard process. Then we have training the care team on the impacts of SDOH and resources available to address them. Then we have stratification of hemoglobin A1C performance rate by 2 or more subgroups at risk for inequitable health outcomes. And lastly, we have examining the stratified data and taking action on it. Next, we will look at the full text question for equitable health outcomes. This question reads, I attest that my organization collects and uses patient population data to assess for equitable healthcare improvements and outcomes in diabetes control. That includes, first, we have an A and B element in this question, adoption of the standard process to A, systematically gather race and ethnicity data, and B, assess patient-level social drivers of health. In question 2, monitoring of care team adherence to the standard process. Question 3, training the care team on techniques to gather data per the standard process. Question 4, SDOH when appropriate. 5, stratification of hemoglobin A1C performance rate by at least 2 subgroups at risk for inequitable health outcomes, such as patients from racial or ethnic groups without insurance, by zip code, and or by other social drivers of health metrics annually. And lastly, question 6, examining stratified data and taking action to address gaps in outcomes across groups. On the next slide, again, we have pulled a handful of resources for your reference. So throughout our Ready, Set, Go guide, we have bubbles that contain tips on how to approach incorporating health equity into all aspects of your care. So we would recommend scrolling through that document to see where those key areas are highlighted. Additionally, again, we've provided you with the American Diabetes Association Standards of Care in Diabetes for 2025, as this resource contains many highlights related to health equity throughout. We also have provided a link for the American Heart Association's Health Equity Learning landing page. This page contains many resources for clinicians and helps them in addressing health equity. Lastly, we have provided a link for the American Diabetes Association Healthcare Access landing page, which provides additional resources for this pillar. And on the next slide, I will review one last resource This one is currently available on our website, so we do recommend checking it out. This resource is the Target Type 2 Diabetes Pillar Resources and Examples document. It is a toolkit for understanding and testing to all of the pillar questions. This toolkit covers the background of the Target Type 2 Diabetes program and its evolution, and provides a rationale for evolving the program. And then the document reviews each pillar and includes all of the pillar questions that we have reviewed today, as well as providing many examples of what would or would not meet the criteria that was intended for each of the evidence-based activity questions. We also have provided an FAQ section for each one of the pillars on questions that we anticipate you may have after watching this webinar. Additionally, we provide the rationale for the inclusion as well as the guideline recommendations. And lastly, we've provided many additional resources to support your adoption of the pillar questions. Again, this resource contains all of the information that was covered today, plus more, and can help to answer any questions that you may have in adopting these new evidence-based activities and pillar questions. With that, I will bring Liz and Dr. Chu back in, and I think we have quite a bit of time for some of your questions. So please feel free to add them in the question box, and we will answer as many as we can.
Thank you so much, Megan, for walking through all of the questions. And I just want to acknowledge that we just shared a lot of information, a lot of really specific breakdowns. So we understand that you might not have as many questions right at this moment, but that when you go to really assess your organization's practices, or when you go to submit data next year and you're looking to consider whether or not you should put yes, no, or unsure for this or that question, that that might be when all of these additional questions come up. So we are hoping that the resource Megan just highlighted will be helpful to you for that, but we're also going to provide additional opportunities to ask those questions live of our national team, as well as being able to work with our local AHA staff on working through those details so that we can attest appropriately. If you do not have a local AHA representative, we would love to get you in contact with someone. So please feel free to reach out on our contact us form. It's bit.ly/AQ contact us, and we can drop something in the chat here in a moment. But we do have a couple of questions that we can get started with. And in the meantime, if any of these perk up a question that you might have of our experts on the call today, please go ahead and add that into the questions feature. So the first questions that I'm seeing are around the standards of care, which were included on all of these different pillars. So I'm going to direct this one to you, Megan. Can one policy or standard of care cover all of the pillars, or would this organization need to create separate standards for each pillar?
Thank you, Liz. That's a great question. So the answer is no, you do not need to create a separate standard of care or policy for each individual pillar itself. We would find it acceptable if organizations had one concise diabetes management policy that their organization used, as long as that policy contains all of the elements that are included in each one of the pillars. So I'll just highlight that the most important thing is that the content elements are included in your policy, regardless of if it's separate policies or or one policy where everything is included together.
Thanks, that is super helpful. I've got one follow-up question to that, and then I'm going to direct a question to Dr. Chu. So the second kind of follow-up question, again, on the standard of care is, my standard of care is followed by all the clinicians, but our organization is very against formal policies. Is that enough to like count towards a yes achievement of these questions?
Yeah, and thanks, Liz. Another great question here. I think our intent for this question is that some sort of systematic protocol is in place that all clinicians are following. So we understand that some organizations may be hesitant to have a formal adoption process for a policy, or that the adoption process that your organization currently uses is just too burdensome to have a formal adoption in place. So we would recognize organizations that have someone managing the standard of care and ensuring that all clinicians in the organizations are using that in a standardized way. I think that the spirit of this question gets towards standardization, so that we can improve care outcomes for everybody in your organization. I hope that answers your question, Liz.
Yes, I think that is super helpful. The next couple of questions do kind of get to a popular topic or unpopular, which is regarding cost, because we know that has such an impact. So Dr. Chu, this question is, we recognize the effectiveness of GLP-1s and SGLT2s, but they are so expensive. Did you take cost into consideration? So did we take cost into consideration when kind of outlining these pillars? And maybe if you could share any additional notes on the cost of GLP-1s and SGLT2s.
Yeah, thank you for the question. So yes, these medications are very expensive, and especially for those organizations who has majority of the Medicaid population, with upcoming potential changes with the reduction in the budget from the CMS, this may kind of change some of the policies on what to treat, like, or how to funnel the treatment for the patient. However, for the purpose of this type 2 target type 2 diabetes program, we are asking for the clinicians to recognize that these medications are the gold standard according to the ADA treatment guidelines, and as long as that is being documented somewhere, or that's the sort of what the organization is trying to pursue for, that will count toward satisfying the criteria. In terms of the cost, I mean, there is a lot of opportunities for the patients to try to access the copay discount programs, and also many insurance companies, they will ask for more prior authorization. So as long as patient is meeting the criteria or the clinical criteria that aligned with the American Diabetes Association clinical treatment algorithm, they will be able to accept those type of medications.
Thanks, super helpful. So similar lines, this is regarding the SMES. So I'll direct it to you, but then Megan, if you have any additional comments, I'd love to hear as well. How can my organization get connected to DSMES services? Does this typically cost money?
So I can speak for how to connect. I mean, so when we think about the diabetes care in general, we usually just kind of, think about the healthcare organizations or clinics, but you could also reach out to the community pharmacies. Many community pharmacies, they do provide this DSME the program, and they are always eager to partner with the organizations. So I think that type of a referral process or that type of a collaboration would definitely be helpful.
Yeah, and
And
I can jump in here as well, Liz, just to say that in our work with many different organizations and helping them get connected to different services, we recognize that not every organization is able to provide a service like DSMES in-house. And so in our work, we've seen many organizations connect with outside partners, as Dr. Chu mentioned, community pharmacies and other community organizations, and you may be able to set up referral pathways with those partners in order to refer your patients to those services. Now on the note about cost, Liz, there sometimes may be a cost to your patient for certain services, and really that is insurance and state dependent. So we'll leave that to up to the organizations to research that, but I would say that in terms of cost, it can vary.
all right, thank you so much. Thank you both for your thoughts, your thoughtful answers to these questions. I'm going to go ahead. We've got a few minutes left. If we get some additional Q&As, we might try and circle back, but I think we've covered the main topics here. So I wanted to just go over really quick some of the timeline takeaways for the evolution, just kind of keep in the back of your mind as you begin to assess this. So as a reminder, the rest of this calendar year, we're really just encouraging participating organizations to assess your alignment with these target type 2 diabetes pillar activities. Next year, we're going to ask you to submit your answers to the new pillar activities in a dry run year, and then we will be taking a look at that data to decide on the new award criteria, which will be announced in 2026 for 2027. We will be sending out the 2026 Achievement Awards with no change to the award criteria, so you don't need to meet a certain threshold for any new awards. They will continue unchanged in 2026. But then in 2027, we'll ask the same questions, maybe tweak the language a little bit if we find any confusing language that we can help address. But overall, they should be pretty stable, and they will impact the 2027 awards. So moving forward, just to wrap us up, I do want to give one more opportunity to ask questions. I do see a question that came up, and it was around if there are any grants and incentives available for organizations to promote better participation in these programs. I think that this is a really great opportunity to get in contact with your local American Heart Association staff. They will be the ones to be the most aware of different grant opportunities. Sometimes there are some through the American Heart Association, but our community impact staff in particular are really wonderful dot connectors to different opportunities in the clinical space, in the community space. Community to clinic linkages is really their expertise. So again, if you're not in touch with a local AHA representative, please go ahead and reach out at bit.ly/AQ contact us, and we will connect you with someone who can kind of help work through these different questions and opportunities. And again, all of the new resources that Megan called out are available at heart.org/target type 2 diabetes outpatient. So you can find them there. In a follow-up to this presentation, we will send a copy of all of the slides as well as links to the key featured resource, and we will have a recording available online once it is able to be closed captioned, which we will send out to participants as well. So I will take one more look at questions, and I see one came in. So I did get a question on the new pillar attestation is not starting until 2027. I'm just going to click back one. So we're going to ask for new pillar attestation in 2026, but it won't impact awards. So we want to understand where the benchmark is for your organization as well as organizations overall. So these questions will appear in the program form on, that is released on January 1st of 2026. But the answers that you provide, yes, no, unsure, they will all not impact the awards until the following year when we ask the same question. So we're kind of doing a dry run year to better understand organizations and also not to increase the threshold for awards until, just right away. We want to give organizations time to process and evaluate to identify the best quality improvement opportunities for your organization. All right, and we wrapped up a couple of minutes early, but thank you all so much for joining us today, and we look forward to supporting you in your achievement of these activities. Look forward to answering your questions over the next year, and appreciate your time today. Have a wonderful rest of your week. Thank you to Megan Polner and Dr. Michelle Chu as well for your help on the presentation today.